if there's an inflammation that it's taking place, it has been demonstrated that inflammation is a source of pain and makes pain become chronic. But if we alleviate pain in some way, if we make people walk again, go out again, go hiking, well, perhaps not go hiking, or go climbing, because when we insert an IPG and an electrode, we prevent them of making some flexion and bending the column for some months to make sure that the fibrosis puts the electrode in place and we don't move it. But yes, if we allow them to have a more normal life, normally that movement will prevent and cure and relieve the inflammation, because inflammation is very related to immobility. If we start moving, we reduce inflammation. So if we allow them to move better, probably we will eventually attack also the cause of the pain. So that's a very interesting comment.
In today's episode on the MedTech 101 podcast, I basically decided to sit down with Dr. Charles Garcia-Vitoria, who is a pain specialist and anesthesiologist at the hospital in Valencia, Spain, and the hospital is called I will try not to butcher this word because it's in Spanish, but it's Hospital Intermutual de Levante, which basically is a hospital for people who maybe have had some sort of like trauma, and by trauma I'm talking about physical trauma, which has caused an injury whilst they were working. And this also led him to found a company called Spinally, which makes an interesting medical device that helps people reduce pain. And this is done by implanting the electrical rod in the spinal cord, which I find very cool. And by doing that, it helps people with chronic pain. So without much delay, welcome to the podcast, Charles.
Thank you very much, and you are right. I'm happy to be here, and you're right. My hospital devotes to those patients that have suffered some injury when working, so it's for workers. So there's a lot of trauma, yes, especially for spine cord, also limbs. So we deal with this kind of people, and I'm an anesthesiologist. I'm a doctor, and I also practice pain medicine, which is a part of the anesthesiologist day to day. Not much anesthesiologists decide to jump into pain science. So I'm kind of a rare or special anesthesiologist. We love this science.
Nice. And just to get started, really, just briefly, just for people listening right now, what drove you into studying medicine, specifically pain medicine, like as you were growing up? What made you choose this particular field? Just before we get started, I think it's quite interesting for people to know like your motivations that led you to this point in your career.
Oh, I don't know if you like football or any other sports game where you can see the referee as the one who has to be silent, and it's not the main actor. But if something goes wrong, everyone is looking at you. That's the role of an anesthesiologist. So you are kind of low profile. And I love this low profile because you can be very professional and take care of the life of the patient, especially when a big trauma comes and you have to go to the operating room. But there's also a nice approach to the medicine that can be done from anesthesiologist point of view, which is the pain medicine, in which you are the leader of the team and you are the one performing the technique. And I'm happy to say that it's not that my family has a lot of doctors. I just had a relative that was exerting medicine, but I always look at doctors as a very altruistic job. So I decided to pursue this dream. And then when you get into the career and you just finish your degree, you have to decide. And anesthesiologist was combining that low profile and main character profile, because you can mix anesthesiologist and pain practice. So it's a very interesting mixture for me. And pain, I think, is one of the most relevant pathologies in the world. And by pathology, I don't think that pain is always a bad sign because, as you may know, pain gives us information that something is wrong and we have to fix it as humans. But neuropathic pain, which is a kind of sub sub order of pain, neuropathic pain instead is a pathologic pain. We don't need neuropathic pain. It means that some nerve is not working properly and is giving us information that has no sense, and it's very painful. So what we address mainly is neuropathic pain in our daily practice.
Nice. And just to quickly then just break it down, when you say pain, and you say pain isn't necessarily a bad thing, and from my own reading that I did leading up to this, and from university, is that usually when there's pain, it's usually a result of like inflammation. But I think before we even start, it's quite important for us to differentiate the two different types of pain between acute pain and chronic pain. And what Spinal is working on right now is mostly to help people with chronic pain, if I'm not wrong. So, like as a doctor, what would you say chronic pain is for people listening?
It's always difficult to establish a certain point in which the day before you are in acute and the day after you are in chronic pain. But 3 months and on, you are starting developing chronic pain. You are suffering for more than 3 months. Some others say 6 months, but in any case, when I receive the patients in my pain cabinet, I usually see patients with more than 6, 8 months, 1 year. That's chronic pain. And that's a way to classify the pain. I think is very useful because in acute pain, there are some therapies. In chronic pain, there are others. And there's in between, there's some therapies that you provide the patient with in order to avoid the chronification of pain, which is a bad thing because if you chronify a pain, it can start making your brain and central nervous system become, due to its plasticity, make the pain permanent or chronic. So you have to avoid the progression of pain. If it's nonsense pain, I mean, if it's not giving you useful information for avoiding certain movements, if it's acute pain, you have to avoid it becoming chronic pain because this is a social economic burden. It's important in all around the world.
Nice, nice, and that makes sense, really. And it's I know pain has always been a problem historically. I think even behind it goes beyond that in terms of like in terms of social problems. Most like drug addiction problems or the spare medication is all linked to chronic pain. So it's quite nice that you decided to start spinally, and as I said earlier, like in a simpler term, that Spinally is basically it's a company that you guys started, and it's you basically have a rod which is inserted into the spinal cord, and it releases electrical impulses to sort of like reduce the pain or to make it easier for people living with chronic pain. How does it really work? Really, I mean, in terms of like how did you get to that point, but spinally in general, like what made you start the company and what made you choose to use what like there's like electric rods inside the spine to help pain.
Yeah, you're right. The pain in ancient times was treated with many solutions, and one of these leading solutions was opioid prescription. There's still a very wide use of opioids, and I don't hate them at all. I think they are very useful in some conditions, and I myself am prescribing opioids, but it has been known by anyone who has Netflix that there's a big issue in the world with opioid abuse and addiction, and it has lead to fatal consequences in many thousands of cases. So yeah, I can try to explain, and as you already know, as you're making your job very well. That explaining things and making people understand things that are quite complex is difficult, but it's a very constructive work. So I will try to do my best to explain how neuromodulation works. I have to say I haven't invented this. Of course, the technology itself of neuromodulation is not my invention. It has been used for decades. What we are doing is trying to make a step further, which will have good implications for the industry and for the patients. But neuromodulation is the way the word we use for explaining how electrical, in this case electrical, therapy can modulate the activity of certain neurons. As you may know, pain is perceived by the extremities or an ending part of a nerve, and it's going and traveling around the nerves to the spinal cord and then to the brain. Certain stops at the brain, and there's a complex circuit in which eventually some parts of the brain decide that what the nerves have taken is a painful stimuli. So what we do is try to cut this systemic circuit and put some electrical therapy in between the distal part and the ending part, which is brain. There has been attempts to neuromodulate and apply electrical fields in the brain, and we're still implanting some of them. The medical community still implanting deep brain stimulators, also peripheral brain stimulators, peripheral nerve stimulators, and what I have more experience in is in spinal cord stimulation, because spinal cord aggregates most of the bunches of nerves that are coming from the periphery going to the brain, and it's a sweet spot for treating pain with electricity. What we do is to insert some little electrodes, which are relatively thin, and allocate them in a strategic point where many nerves can be. And when we apply certain differences between anode and cathode, we create an electric field that we can even modify depending on the needs of the patient. We can modify some certain patterns, and we create that amount of energy in some part of the railway or the road of the pain. So what we do is try to make the neurons confused and tell them that you are not longer bringing pain to the brain, but you are now bringing some tickles or some other paresthesias or some other feelings that will mask the pain. That was the classical use of neuromodulation. Still, there has been other approaches, and we are also implanting some new methods of new implants that can make this even changing pain for nothing, in which the patient feels nothing, and we don't have to switch or change the feelings. We are not substituting pain for tingling, but this is a deep conversation we will have to have. But basically, this is what neuromodulation means, especially in the spinal cord. But if you ask what I'm doing different, me and another mate is an engineer that has been working for many decades in the field of neuromodulation. We decided that we could go farther and design a different electrode. Okay, so that's what makes Spinally a very interesting company, because usually I've been working as an anesthesiologist, and many of us have been working in the epidural space. Epidural space is where we allocate catheters and we provide anesthesia for pregnant women, for cesarean delivery, for some trauma surgeries. That's epidural space. And epidural space is a space that is lying like 1 and something millimeters behind the spinal cord. And in between, there's a dura mater. This is a meninge, that it's a barrier that separates epidural space from spinal cord. So what we have done is to design a method to not remain in the epidural space, which is the current use of the technique, but insert the electrode in the intrathecal space, which is very close to the spinal cord, surrounded by some kind of fluid, which is the cerebrospinal fluid that we humans fabricate every day, and it's very conductive. So this is the big step we are taking now, changing the spot and designing a specific electrode for intrathecal use. So this way we can use thinner electrodes because it's very, very efficient due to the conductivity of cerebrospinal fluid, and also easier to implant. We can continue this by saying that the neuromodulation techniques have evolved a lot, and lately what we have been trying to do as a scientific community is not only to stimulate the spinal cord, but also to listen at the same time what's happening in the spinal cord to adapt the stimulation at every millisecond. So it's a closed loop. We receive some information with the same electrode, and we, in the lower segments, we stimulate accordingly. So with the intrathecal approach, this is going to be much more precise in the future.
Well, that's impressive. And just to simplify it further, basically what you said is, and correct me if I'm wrong, this is like the simplest explanation that I understood is that like for people to understand this, it's like, let's say you got one big city and you got one main highway. This highway is coming from different small towns, etc., that send messages to the big city, and the highway is the spinal cord essentially. So every message that gets to the big city has to pass through this highway. And what you've basically done is put sort of like essentially like police roadblocks in this highway so that not everyone is just getting to the city. And by doing that, you can, if there's like a little messenger there with pain going to the city, which is the brain, you can, the police roadblocks that you've put can prevent that from getting to the city. Therefore, then the brain doesn't register that particular pain message that would have come with this little messenger. And to make it even more interesting is that the location where you're putting this particular metal, not metal, but this electrical rods, which are very thin, is in between the space, because within the spinal cord there is the main bundle with all the nerves, and there's like fluid around that, and the fluid is conductive, and everything works on electricity, like the human body works on electrical impulses to send this message. So it's quite impressive because and this leads sort of like to the next question that I have. The and this is just from the the device alone. So for this electrical, like sort of like conventional epidural leads that you put inside the spinal cord, are they connected to a device outside of the body, or how does it read the signal? How are you guys overcoming that particular challenge?
Okay, yeah, I think that the example of the highway and the policeman could work perfectly. He should, make some nuances on that, but I think it's very, very good to explain people how this works. And yes, there has to be a source of energy, and by telling that we are putting a source of energy, we mean a pulse generator. So there's some little external unit that has to provide the electrode with energy to carry until we reach that sweet spot that is called, in this case, spinal cord. But I wouldn't say it's an external unit, because nowadays what we implant, the status quo of the stimulation, is an epidural, as said, epidural lead that is connected to an IPG. IPG are the implantable pulse generator, and it's implantable, but because it has to remain inside the body. So it's like a pacemaker or some other devices that we implant near tissues. So the patient is carrying the implant at every second of his life. So it's a permanent implant that we are allocating. So this is more or less. Well, I'm non-smoker, but if I had a tobacco, box, that would be double the size. So the IPG is half the size of a tobacco nowadays. A tobacco
Box.
box.
Nice.
So that is the thing that we are implanting. We're implanting the electrode, and then we are connecting that electrode to the IPG.
And
So
IPG is
we are
outside the
now.
body. Sorry,
No,
is the
that's
it's
it.
inside?
So
It's internal.
IPG is like a pacemaker you are
Oh,
going
nice.
to wear forever.
Mm,
Normally, we implant it in the belly or subgluteus. So we have like in the buttock. So that's why people has to wear it. It's not very heavy because technology advances a lot, but we have to implant it. The technology is advancing, and the size is getting lower and lower. So that's another interesting discussion. But yes, there has to be IPG. There are other systems that rely on external stimulators that you have to apply every time you want to get some neural dose. But the current stimulators now are via IPG. This is for spinal use.
nice.
Deep brain stimulator is different, and also the peripheral nerve stimulator is different.
Well, that's really exciting. I'm actually I have to say, like even though I did pre-reading leading up to this, I didn't expect it to be this exciting because not only are you like creating this as a solution for people with pain, but you're also doing it in such a way that it's not invasive to normal life. So like you can put it in the belly, men of with belly fats. I don't know if it's under the fat or not, where you place the IPG. But with most in a normal person with normal body fat, you might not even be able to see it because it's to be hidden under the fat layer. So someone might not even be able to see. And you also said you could also put it like essentially like in the buttocks, which is quite funny. And that's good. But then like how long does it last? Like what's the sort of like lifespan can this exist in the body before you have to change it? Because I know some medical devices they tend to have a specific lifespan. Is this for someone's entire life? And like how did you guys how did you guys overcome that particular barrier?
Oh, the normal life of of an IPG is it can last forever, but the hardware inside it depends on what is the methodology we are using or the technology that is inserted. It depends on this. Some of them are rechargeable, so you just have to put it 1 to 2 centimeters below the skin. It depends on if it's fat or muscle. It depends on the patient body. But some others are non-rechargeable. If they are non-rechargeable, the battery lasts depending on how many how is the amount of the energy you are trying to get to give to the patient. It will last. The battery will last for 5 years, 8 years, 10 years. It depends on what the use is. But the rechargeable, if they have no problems with the hardware, can last forever. Okay, so,
Wow.
so they are designed to resist. To be clear, we are as finally we are not
Mm,
mastering the IPG
okay.
because IPG creation and perfectioning has been a long career, and there's a lot of good players in the market. So we just want to be the masters of the electrodes. The thin electrode is our main reason of being here. So we will
Nice.
connect to others IPG because we have good
Mm,
partners in mind where to connect the IPGs. We don't have to develop the whole system, but to be the more experts in the intrathecal lead implantation.
nice, nice. It's exciting you say that because like I know some companies that do this kind of approach. They say it, and it's a normal joke that they say like during the gold rush, other people are running to buy mines or to dig and stuff, and basically just some people make fortunes by selling the shovels that people use. So you don't have to necessarily own a mine. You just realize okay, there's already an existing thing, and you're adding a specific element to the market, which is going to be changing like how people experience pain, etc. So and in terms of like the efficacy, the clinical efficacy of the roads, or the epidural nodes you guys are implanting in the body. And I know usually doctors, when you go to the hospital, they ask you to measure your pain on a scale of 0 to 10 or something like that, depending on how you feel, because it's hard to actually sort of like quantify pain, but people can measure it by themselves to say, okay, maybe I'm feeling 6 out of 10 today, 7 out of 10. Like after people have had this node insert, like implanted in them, like what has been the changes in their pain? Does it go from zero? So does it go from 10 that I can't sleep, kind of pain, to like I don't feel any pain at all? Like how what's the reduce impact on the patients receiving this?
Oh, for sure, there are extreme cases in which we can leave the patient with zero pain. 10 to 0 is very strange case, but it would be, well, it's always pleasant to have this kind of pain reduction. To be clear, we are in Spinally are in the animal phase now. We are designing the first protocol in animals that will take place in months after we close this present round. We can talk about this later. But if we jump back to what is the current stimulators we also implant of other companies such as Medtronic, Boston, Abbott, Saluda, there are many big players in the market. This works more or less like this. We first, it depends on the doctor, and others could say differently, but we normally insert the electrodes in the epidural space with the available implants now. And when we implant them, we leave them in the epidural space for 1 week, connected to external, this time is external IPG, for treating the pain and trying to delucidate if the patient is having a good reduction. And by good reduction, we expect to have 40 or 50% of the pain reduction. If they were at 8 out of 10, they have to be at 4 out of 10 with the stimulation. And then we decide to go for a second surgery, which is exclusively to connect the implanted electrodes to the definitive IPG, which is going to be inserted in the buttock or belly or wherever we decide, depending on the patient's body and preferences. So this is a second time of surgery. And this is how it goes. And as said, in terms of efficacy, there have been also now good progresses on this, and we can expect 60% of pain relief. But I have to say that pain has demonstrated, even if we take it very, very quickly and we don't allow the pain to chronify too much, it has many sources. So it's not only the neuropathic pain, but there below that there's something. Some other sources of pain on the back and legs pain, which can lead to arthrosis or other conditions. So we rarely make all pain disappear. We can deal with neuropathic pain very well, and we can provide a good alleviation of pain, but it's very rare that we treat with electricity the 100% of the pain origin.
Okay, nice. It makes sense, really, right? Because I think, like alluding back to what I said, essentially was that what usually causes pain is after you've gotten an injury is usually inflammation, right? So, essentially, we can't really heal some sort of inflammation that has happened over a long time, and that's why we've decided to intercept these messages going to the brain, so that it's not perceived as painful. So the source of pain will always be there. So I guess this constant modulation that needs to happen all the time. And if it goes from 8 out of 10 into 4 out of 10, I think for most people, that'll be the difference between not having to take, like pharmaceutical drugs every day. That's the difference with them being able to get their life back, to be able to continue, go outside, go camping, go hiking, etc. So that's still quite revolutionary in the sense that it's still going to mean a lot for people. And just out of curiosity, I think people will be wondering, like, you mentioned one thing, like animal models. Like animal models, just to simplify it for people listening, is basically when before any implant can be put in a human, or any medical device can be put in humans, it has to be trialed in animals first, just so that we get, and then it goes to phase one, clinical trials, phase two, phase three. And every point it gets better and better. And the idea behind that is so that we don't, by the time it gets to humans, it's as safe as possible, and we're not putting anyone in the line of risk. And like in terms of that, like when are you guys expecting to sort of like hit the markets? I know like in medical devices, it's kind of hard to estimate this, but do you guys have a timeline on when you'd want to be like on market by?
Yeah, regarding your first comment, I think it's very interesting to point out that if there's an inflammation that it's taking place, it has been demonstrated that, yeah, inflammation is a source of pain and makes pain become chronic. But if we alleviate pain in some way, if we make people walk again, go out again, go hiking, well, perhaps no go hiking, but or go climbing, because when we insert an IPG and an electrode, we prevent them of making some flexion and bending the column for some months to make sure that the fibrosis puts the electrode in place and we don't move it. But yes, if we allow them to have a more normal life, normally that movement will prevent and cure and relieve the inflammation, because inflammation is very related to immobility. If we start moving, we reduce inflammation. So if we allow them to move better, probably we will eventually attack also the cause of the pain. So that's
Well,
a very interesting comment, and what you told was very interesting. And regarding the second, yes, you are right. We and all we have to do is demonstrate in bench surgeries before the living animal, then with in vivo tests with animals, and then we can jump to the what we call first in human trials. There's a lot of regulatory issues in here, and it has to be like this because, as I said, we are implanting near the spinal cord permanent electrode, and it has serious implications if we, let's say, have some kind of reactions like meningitis or arachnoiditis or some other infections or trauma provoked by the electrode. So we have to be sure that it's working in animal and as close as the human possible. Of course, experimenting with chimpanzees and monkeys is very expensive and very you have to justify that your electrode or your device has passed the previous test. So the first animal test in our case will be in sheep. Sheep model is a model that I have been working in for years in other inventions and other in other research programs. My PhD is also in sheep for very similar purpose to treat the dura mater tears. So we expect to be conducting the first in animal, the first in vivo test in probably 8 to 10 months. And with this animal test, we are going to compare epidural and intrathecal approach in many ways. Obviously, you cannot ask the sheep what is the pain she is feeling or he is feeling. So we have to use other methods, but there are validated methods for other by other researchers that will help us elucidate if this is working better or not. Hopefully, it will be working much better than what we have now. And then we have to do the regulatory pathway that will bring us to human probably in 3.5 or 4 years. That's answering your question. That's
well,
very quick.
yes.
That's very quick. Perhaps there's some delay and we make it in 4.5. I don't know. It not depends. It doesn't depend all on Spinally, but we will try to go quick to the market because what we are using are same materials that have been tested safe for other purposes, intrathecal and epidural leads for other purposes. But that may simplify the question.
Nice, nice. And just to add on quickly there, 4 to 5 years is actually quite a very fast time because in medical devices sometimes it can take up to maybe 10 years before something is on the market. But what also makes this faster is that neurostimulation is already like an existing technology, so they can launch what they call a 510(k) approach in the US, and because it's basically benchmarking it versus already currently existing devices, so that like halves the time kind of speeds up the process getting to market. And I just wanted to say that for guys listening, so they also know like what you mean. And like just looking at the time and everything. Like I still want to ask you as well, like in terms of like the future of treating pain really? Is this the future where we're going towards, where we can now sort of like intercept this like pain signals before they get to the brain? And like, what do you think is going to be, what do you think the pain treatment would look like maybe 20 years from now? And feel free, you can go as far as you want. It can be science, it can be a science fiction answer if you want to give it, because it's quite exciting to see how things are progressing and what you think, since you're working in this kind of field at the moment. So how will pain be treated 20 years from now?
Oh, 20 years from now, we will still have the FDA, so it will make things stop a bit. So it's not going to science fiction, but it will be a very realistic approach. But look to this in this way. If we want to treat some neurological condition, where this nonsense is to treat it systemically, and by systemically, I say, and I mean, getting some pills that will travel all around the body, affecting every cell, even if some liver cells or bone cells are not ill. So targeting the appropriate bunch of neurons, neuropathic pain, is the future. And this future has been happening so far. So we are not that far away from what in 20 years we will be doing. I assume that the big revolution, besides getting intrathecal, which I think is a very good step that has to be naturally taken, will be listening better to what neurons are telling us. So sensing instead of only treating. So we will devise some implants that are taking information out of the decoding some information of the brain or spinal cord cells, and applying the correct amount of stimulus at every millisecond. So you will kind of have full mobility instead of being subjected to some restrictions, because you are going to feel like some pain out of the movement that you provoked it to the electrode. So it will be thinner electrodes, very good at listening at what tissue is telling, and very, very, very capable of giving a full amount of bandwidth and potentials and some other parameters that we have to measure and apply. So the electricity is going to be very specifically used for treating efficiently in deep layers of the neuron of the spinal cord, and I think that's the future for sure.
Oh, nice. That's exciting. I can't wait. To me, it sounds like at some point we might not need painkillers anymore. And I think if we can get to that point, it's gonna be good for a lot of people, and just to get these implants. And yeah, and just like before you go, there's one question that, like one of my friends asked me. Like, I've got some friends who are studying medicine, etc. right now, and because they've not really done such a procedure, like how difficult is it to insert these nodes, like, in that, sort of like, first of all, you have to pass through the spine, and obviously it's a high risk environment because you don't want to sort of like damage the spinal cord in any way. And like, how difficult is it for you to implant this nodes?
Uh, of course, what I told at the very
Mm.
beginning is
Yeah.
still true. We have to be anesthesiologists to become interventional pain practitioners, and also neurosurgeons are good practitioners of this kind of implanting techniques. So assuming that you have the skills to treat and puncture patients, it's not that difficult. But obviously for some medical student or noob, it's going to be very, very risky. Yes, we do it in a very strict ambient, like in the operating room with X-ray, echo, ultrasonography, and so on. And then we have to rely on our hands.
Nice.
To be honest, when we implant nowadays systems, the epidural systems have to be very cautious, because we are carrying a very, very thick needle that has to be placed in the epidural space. If we go too far, we break the dura mater, and as the needle is so thick, the the breach and the leak of the cerebrospinal fluid can lead to other complications. So we have to be very careful and be very specific when we put the tip of the needle in the correct place. So that's difficult. And with spinally, what we aim is to get intentionally intrathecal, so intentionally break the dura mater, which with a thinner needle, but it's way easier because this is a technique that we, as anesthesiologists, do every day for other purposes, such as puncturing and making you anesthetize from lower limbs for arthroscopy of the knee or total knee replacement or something like that. So intrathecal approach with a thin needle is not that difficult. Of course, you can make a big mess if you are, too rough or you are distracted, but I think it's going to simplify the method.
Nice. Thank you. Yeah, I just had to ask that for some of my friends who are still new doctors and stuff. So yeah, so I think this gives them some reassurance that they'll need to first gain some experience, and sort of like neurosurgeons, guys with much more experience later down the line in their career are the ones who are going to be mostly carrying out this procedure. So yeah, thank you very much. Charles, for coming on the podcast. I think there was quite a lot of information learned, and a lot of people will be happy to listen and learn about this new device. And in terms of Spinally, I'm gonna keep tabs on what you guys are doing, and I'm gonna be like if once it's on the market, I'm happy again to bring you back, and we can look back now and versus what the product you have on the market, what has changed. And but I'll also be putting the descriptions below, like the link below, if guys want to find you, where they can find you, where they can contact you, etc. So yeah, thank you very much.
Thank you very much. It's been a pleasure. We are now in a funding round. It's 70% complete for this first animal in vivo trials. I think it will close quickly. Let's see. It's not my role to fundraise. Of course, it's CEO stuff. It's not me. But yeah, that's the momentum we have, and I think we are in a good position. So yes, I'll add to the description because we are now making normal people invest through a crowdfunding campaign, which is very interesting from many points of angles. So I think that will also help Spinally grow faster. Thank you for your enthusiasm and also for your work in this field, which is very, very needed, in my opinion. It has been a pleasure.
Thank you.